Let's talk about lung cancer. And this is one of those cancers that, we hear about them. People who smoke sit in the cigarette packs by law. They talk about, cigarette smoking could lead to lung cancer and on other cancers as well. But let's understand it today much further. Lawrence Atundo Murunga is a program manager at the Moi Teaching and Referral Hospital and AMPATH Oncology Multinational Lung Cancer Control Program. He joins us in the studio now. Lawrence, good morning.
Good morning.
Habari ya Eldoret?
Eldoret kwa wazima. We are very optimistic. We are praying very hard for the rains to come. But we are doing well. And in matters cancer management, we are doing what is best at our level to ensure that then we are able to manage this disease that is currently the thing in healthcare.
So you're saying it's not yet rained in Eldoret?
Well, for a while, though I must confess at this point that I haven't been there for the past week, but reports are that there were some little rains, I think yesterday or the day before yesterday, in some part of the Eldoret. But generally, usually, we usually get rains much earlier. Though, as you said in the beginning, we are not yet April. So usually we do get rains before April. We remain optimistic that as April approaches, we
one of the reasons we are not in April. It has not rained in Eldoret. Bado April ijafika.
Because ingekuwa April. April
ingekuwa the peak of rain. It starts raining around mid-March in April.
Mid-March.
So we're in early. So we're in Eldoret. So we're in early March.
We are indeed. But we're very resilient. Most of our farmers are quite resilient, and we remain optimistic that indeed when the rains hit the ground, we'll also be in a position to actually hopefully hope that the seeds that we've already put there will germinate.
Moi Teaching and Referral Hospital is one of those level 6 facilities in the country, and second to KNH as one of the oldest referral hospitals.
Indeed.
Now we have several others.
Indeed.
In other parts of the country. So what exactly do you do at MTRH as an institution?
As an institution.
Not as Lawrence.
Oh, yeah, indeed. Quite a good question. MTRH is as you mentioned, is the second most, biggest public hospital that embraces care with patients and also envisions to ensure that it becomes one of the leading care centers. Primarily, MTRH has partnered with a lot of other partners to ensure that it provides care to the Mwananchi, more so within the western part of the country, and also even the other regions that are neighboring us. We see patients all across, even from Uganda and Rwanda. So it's quite a rather big facility that then cuts across all specialized areas. It's also a teaching hospital. Remember, Moi University School of Medicine is also affiliated to Moi Teaching and Referral Hospital, and has been very key in producing some of the best doctors within this country. So it is primarily a multidisciplinary, cutting across care, training, and also research. And it's one of the best facilities, I would say, personally. You get the privilege of working there or even visiting. Yeah. So with regard to partnering, and that's where AMPATH comes in. AMPATH is kind of a three-legged institution. I can't really say it's an NGO per se. And I know by this time you understand when I talk about three-legged, when you look at the issue of politics.
Tunataka fourth leg, bwana. Sisi watu wadogo.
So in this regard, with three-legged, we are looking at the different approaches it has. So AMPATH works with Moi Teaching and Referral Hospital, with the Ministry of Health through Moi Teaching and Referral Hospital. It also works with the Ministry of Higher Education and Learning through Moi University School of Medicine or School of Health Sciences. And it also works with a consortium of other universities led by the Indiana University, which then comes together more so with regard to funding and other areas that then are able to be worked on. Primarily, if I would say, AMPATH began as a HIV care program almost over 20 years ago, but it has grown to embrace other approaches, including the non-communicable disease approach. And this is where now the AMPATH oncology comes in.
What does AMPATH stand for?
AMPATH is an acronym. It stands for the Academic Model Providing Access to Healthcare. Previously,
Academic Model Providing Access to Healthcare.
Yes, indeed. Okay. And with AMPATH, we also, as a program, as we said earlier, it began as a HIV care program, but it has grown to embrace other non-communicable diseases. With this, we are looking at AMPATH venturing more into patient care as a priority, training, and in this case, we're talking about issues of training healthcare providers. We have a lot of programs that are affiliated to AMPATH, including higher diplomas in oncology and in nursing. We also have training in specific areas like short-term training, both short-term and long-term trainings, and we also have the research component.
Are these accredited courses?
Yes, indeed.
Provided through which institutions?
Through Moi University. I mean, Moi University together with Moi Teaching and Referral Hospital.
All right.
Yes.
Why I asked the question is because I want to head towards affiliation.
Affiliation, indeed.
Yes, because if AMPATH was involved with HIV care and treatment, then it stands to reason that they had affiliations outside the country.
Yes, indeed.
Who are the affiliate organizations or institutions that they were affiliated with?
I mentioned before that there's a North American consortium of university led by the Indiana University that were primarily, pioneers of AMPATH. But currently, as we speak, there are many other donors or willing partners that have come on board to actually support AMPATH-related program, including the AMPATH Oncology. Because in the AMPATH Oncology, we are looking at both solid and blood cancers. And there are several other programs besides the lung cancer program that I'm involved in. There are several other programs that deal with both solid and blood cancers. And almost each and every of these programs are funded by willing donors within and without the country.
And what percentage is the government involvement in all this? Because a lot of the funding that you speak of is partners. Yes, exactly.
Indeed. Well, at this point, I might not be very precise or privy to such kind of information in regard to what percentage. But what we know is that by virtue that we work with Moi Teaching and Referral Hospital, there is a marked percent from the Minister of Health in providing expertise and every other thing, because as a program, we don't work in solidarity. We are closely knitted with Moi Teaching and Referral as well as Moi University. But as a direct fund per se to programs that are run by AMPATH, I think at the moment I may not be in a position to really quantify per se, but I'll say that we work closely with the Minister of Health in partnering in other areas. I've not had or had the privilege to know whether there have been any kind of like exchequer to get particular funds within some of the programs that are run, but we've had programs that have been funded through Minister of Health or WHO through Minister of Health, like the PIC4C programs that deals with other elements, including the non-communicable, hypertension and diabetes. So we have the involvement of the Minister of Health quite closely. But as far as monetary and funding is concerned, I'm not quite sure that there's been a lot of contribution. And talking about the involvement of the Minister of Health, as a lung cancer program, we've worked quite closely. And I remember even the World TB Day had a privilege to be hosted by the TV, Prime News, and we discussed a few things. And in regard to that, we were working quite closely with the National TB Program, together with the National Cancer Control Program, to come up with some of the guidelines and algorithm on how we can be able to integrate lung cancer screening in national TB, rather in TB clinics that are run by the Ministry of Health. So that kind of relationship is what I'm quite sure of, and with know-how on how we integrate and work together.
So, I mean, obviously you have a skew towards lung cancer. Can you give us a little bit of information about lung cancer and its spread in the country? I mean, obviously we're looking at the most common cancer on the planet.
Indeed.
Is lung cancer.
Indeed.
What does it look like in Kenya?
Interesting. And also quite glad that you actually recognize it as the most common. What you're looking at is lung cancer in one way or another, I could say where we stand is that it's a cancer that is, especially in this country, less commonly reported. Because according to the Global Can in 2020, lung cancer was reported as number 14 of all the cancers in the country. Yet, when you look at the mortality rate, it was actually leading. On average, out of around 794 cases that were reported in 2020, mortality rate was around 729, leaving a percentage rate of approximately 92%. Yet, when you look at the most commonest cancer, lung cancer came in as number 14. And this is primarily because it is not easily diagnosed and therefore not usually reported per se. Worldwide, when you look at it, as you had mentioned, lung cancer actually comes in almost the second most common at around, when you look at Global Can 2020, is around 2.2 million cases, following up with breast cancer. But when you look at mortality, the mortality was quite high at almost 1.8 million cases of death. So holistically, even when you look at Moi Teaching and Farrell Hospital, where we are, lung cancer comes in almost the fifth cancer as per the rates. Looking at the numbers of patients that are presenting with solid cancers. Yet when you look at the mortality, it's at 75% mortality. So generally, I could confidently say that lung cancer is the number one killer cancer, by virtue that it affects one of the most vital organs, the lungs, and that's why probably it is the other component that quite closely relates with lung cancer and the mortality is because it's not easily diagnosed.
Sure.
A lot of patients with lung cancer are being managed for other conditions, especially pulmonary tuberculosis. And that's where we come in to create a lot of awareness within our catchment, with the clinicians, with the doctors, especially in the peripheral facilities.
This has been a thing,
Yes.
that a lot of people then who present with lung cancer, by the time the correct diagnosis is being made, they're usually in the later stages,
Indeed.
3, 4, and then, terminal.
Yes.
So, if we're saying that, sure, breast cancer, a big deal here, but like you said, a lot of people then the breast can be removed and you can still live.
Yes.
Very difficult to have your lungs removed and then you survive, right? So if the screening, or rather if the diagnosis has been so difficult, what's being done right now to be able to say, look, we're not dealing with pulmonary tuberculosis, we're dealing with lung cancer?
Indeed. Very good question, and this is where we come in, and that's why I'm quite grateful even for Standard Media Group to give me this opportunity through SpiceFM to discuss. One of the things that we reckon as a care program in lung cancer is that lung cancer patients don't come late. We diagnose them late, because as you mentioned, patients come in and probably, they're at home and they're taking some, cough syrup, they're doing some kaluma steaming and they're taking up some marubaini or whichever thing they're taking before they actually approach the first care the first care. So then after that, then they approach the clinics and usually when you show up to the clinic and you have a cough and you have a chest pain, there are things that we'll obviously start to think of.
Right.
You see, it happens even in general life when as a clinician, when a young lady approaches the clinic and she has nausea and she feels like a headache, she has a few chills, the first question I'll ask her is, when was your last monthly period? Generally because I think towards that area.
Right.
Because they're primarily sexually active, so probably they're pregnant before I can start thinking about malaria or what have you. So it is actually a good clinical practice that indeed patients who show up at the clinic with cough and other related pulmonary condition will first of all be asked questions regarding to tuberculosis, pulmonary tuberculosis, which is fine. And as per protocol, diagnosis of pulmonary tuberculosis can be made both clinically and bacteriologically, meaning you can do a gene expert for the sputum, and you can also be able to ask clinical questions and actually make a diagnosis clinically. So most of the patients will be diagnosed clinically with pulmonary tuberculosis.
Right.
And that's where we come in, because what we're doing right now is to go back to the baseline, household level, and ask and work closely with the community units. Sensitize the community health workers and let them know that indeed, if someone has a cough that is pathological, they need to get help.
Okay.
And if they need to get help, they need to be referred from their households to the nearest health center, not to take cough syrups per se, unless it's prescribed. Then at the peripheral facility, that is the community health centers, what we are sensitizing the clinicians at that base is that if someone comes in, rule out tuberculosis. Indeed, it's okay. We are not trying to change the protocol. We are saying, indeed, rule out the tuberculosis if it's there. But if it's not there, think again. TB responds very well on treatment. If you give someone treatment, even if it's clinically, and 1 month, 2 weeks down the line, they're not responding, then think of it. And that's why we also have this slogan that, if it's not TB, then what is it?
Right.
Because ultimately, that is the question the clinicians need to ask themselves.
A technical, maybe almost mathematical question here
Yes.
is that if you had a ballpark figure, how many people who present with P tuberculosis then later present with cancer? Or are there some people who then present with this tuberculosis and that is actually what they have? Because then you would say that it would be a bit worrisome if the load was that most of the people who present with this tuberculosis end up having then the lung cancer. Is it that much of an issue?
Well, this is something that we're actually working on as a program. We are looking at what we refer to as the TB sequelae. What are the consequences of TB infection? Because we're realizing through research that indeed lung cancer can develop following injuries to the lungs, and TB causes injuries to the lungs. But now on this approach, the one I'm speaking about, that if it's not TB, what is it? The question here is that most of the lung cancer patients first begin treatment of tuberculosis because the signs and symptoms are not different. They're literally the same. So we find that most of these patients are missed until, as you said earlier, the late stages. They're actually diagnosed at a much later stages, yet they have been with us in the clinics. So it is something that we're working on, and we're looking at the patients who have been treated previously, especially those who have been treated by virtue of bacteriological confirmation.
Okay,
And indeed,
in English, what does that mean?
it means that you actually took sputum, took it to the laboratory, looked at it, and identified the microorganisms that then causes TB.
Okay.
Those ones are patients that are almost obvious they have TB.
Okay.
But the bigger lot is the ones that are diagnosed clinically. Because remember, both ends are acceptable by the protocols that are there. They're acceptable to be diagnosed through checking the sputum.
Okay.
And also by asking clinical questions. And these clinical questions, when they're asked, the signs and symptoms of lung cancer are similar to the signs and symptoms of tuberculosis. So it's not a mistake that the clinician then enrolls this patient to begin anti-TB medication. It's very much in order. The only tough thing is that they need to show marked improvement after a period of time. Otherwise, that is when you ask yourself a question, then if it's not TB, what is it?
But if I may ask the question, the question you ask is a valid question. But there is a rapid test for TB.
Indeed.
Gene expert.
Gene expert.
Now, how much is there proliferation of this particular process in our hospitals, so that instead of simply diagnosing syndromically, you sort of like get someone to go through a test that will give you a clear indication of what it is? Yes.
I get the question. This is very interesting, and this is where the challenge comes in.
Yes.
TB clinics, the National TB program has done a good job by making sure that TB care is much closer home to patients than some of these other initiatives that we have. Now, what happens is this: most of these clinics are not privileged to have gene expert diagnosis, for example. That is one. Secondly, the TB treatment protocol, diagnostic protocol, still embraces the clinical approach for TB care. I remember there's a time when I used to be in the clinic, and the patient will walk in and they will have this, I'll ask them questions and they're coughing and all that, and I'll say to my colleagues, you know what, I'm putting this one on anti-TB medication. I'm giving them 2 weeks. They'll come in changed. And sometimes it actually works because the clarity of the diagnosis cuts across both the clinical and the gene expert, as you've mentioned. So we can't rule out the clinical component of diagnosis, because then if we do that, there are a lot of patients at the peripheral sites that are not privileged to have gene expert to be missed out on anti-TB medication. And this is the good part. It doesn't hurt for you to take anti-TB medication. They're basically antibiotics. But what hurts is when you're taking those medications and you're not improving and you're still being asked to continue taking them. And that's where we come in to make sure that then we sensitize the clinician and the nurses to ask themselves this question. And usually when we say, if it's not TB, what is it? We're not saying stop taking anti-TB medication, stop treating clinically. No, we're saying, okay, well, continue treating clinically, but then refer this patient for further evaluation. Let us do a chest CT, to see if there's actually a mass in the chest. Because, as I'd mentioned to you, when you look at the pool of the patients we have, over 95% of our patients have been previously treated for TB. So what does that mean then? That's where the entry point is.
Interesting.
Yes, because the patients will have a cough. And lung cancer, interestingly, doesn't begin with chest pains, for example. It begins with a simple cough. So by the time it's getting to chest pain, the mass has actually grown. It's actually compressing on other vital organs. You're having difficulty in breathing. You may actually have hemoptysis, or rather coughing blood, or you may as well not have those kind of signs of coughing blood. But you still have a cough. So it's quite closely related that if you're not very careful, we miss out on these patients. And that's why we have come quite close to working with the National TB Program to integrate a case-finding initiative. I almost called it screening, but I wanted to tell you that the challenge with lung cancer is not easily screenable.
Okay.
So we're actually finding cases, because when a patient presents, they're already having signs and symptoms. Screening is when you identify a patient that is okay, like the way you are. I've seen you have a cough, but it's not pathological. You come into the clinic and you're okay. And your age is fine, and look at you, probably you're smoking and you're probably exposed. Then I take you through a certain procedure to identify if you have a lung cancer. Then that is screening. But if you come in and you already have a cough and you have this chest pain, then that is not screening. So we're integrating case-finding initiatives within our TB clinic so that we are able to capture the TB, rather the lung cancer, much earlier than we will be if you were not to integrate. Yes.
28 minutes to 8, Kenya's biggest conversation. Let's take a quick break. We'll be back shortly after you take a look at the weather and traffic.
This is the Situation Room.
There's a message on social media. Lak Chemkani Minor says, this is wonderful. My friend Lawrence, shout out to you.
Thank you very much. Okay, I appreciate it.
Lawrence Atundo Murunga is the program manager for Moi Teaching and Referral Hospital and AMPATH Oncology Multinational Lung Cancer Control Program. We're talking about understanding lung cancer and what the work that they've been doing in terms of research and looking at care and treatment for lung cancer. Just before we took the break, you said it's actually very difficult to do screening for lung cancer. The others we know, there's mammography, there's a pap smear, there's
even physical examination,
physical exam, there's a prostate screening. Nowadays it's improved, it's done in a different way.
Indeed.
Not the old way.
Not the old intrusive
Not the old intrusive way of doing a prostate screening. So normally, how then, are you saying there is no screening method for lung cancer?
There is indeed. In much advanced nation, healthy populations are subjected to what we call the low-dose CT, which can be able to identify, and or recognize masses at its very lowest level. Indeed, it is something that some of the advanced nations are actually taking up. The challenge with carrying out screening for lung cancer is these two approaches. One, we want to look at which is the more hanging fruit, which is the low-hanging fruits per se. When you look at screening, there are other initiatives that we need to take in place, and screening of lung cancer is not an easy or a cheap initiative. It is something that is quite expensive. To subject a healthy population, by virtue of their age or whatever criteria you're using, to a very expensive procedure just to find out if they actually have a lung mass, while you're leaving a bigger population which already has a bigger mass and already have signs and symptoms, then it's more prudent that we begin, first of all, with clearing out the bigger lot of patients who already have signs and symptoms, then now trickle down to the patients, rather to the population that is yet to manifest with signs and symptoms. So that is the challenges we're facing, because even the diagnostic procedure, the screening procedure for lung cancer is quite an expensive venture. The other component is we want to look at the criteria. Currently, if you were to embrace the criteria that is taken up by the American Cancer Society, we may miss out a lot of our population. One, because the criteria says, you must be smoking for a certain period of time for you to be subjected into a screening algorithm, or you must be of certain age, 50 or 70 and above, because it is assumed that lung cancer is a disease of the aged. But today, as we speak, we have in the program patients who are as young as 20 years, as young as 19 years old, diagnosed with primary lung cancer.
Are they smokers?
Primary lung cancer is the one that actually begins in the lungs. They have no history of smoking whatsoever. They are young people who came in with symptoms and signs and symptoms. We had our doubts. We thought this is completely something else. We took them through an evaluation procedure. We saw a mass in the chest. We biopsied it, only to realize actually primary lung cancer. So that criteria will fall short of it. And it's very difficult then for us to say then every Kenyan, every individual of whichever age be subjected to a low-dose CT scan, because we must also be able to understand this is a procedure that can exacerbate other conditions. Subjecting a healthy population to unnecessary, raise is also completely not advisable. So we are looking at so many things, and that's why at where we sit right now, we are thinking finding the cases is much an easier way first. If we can be able to sweep the entire population of cases, then now we can start thinking of how we can be able to embrace the low-dose CT in other areas. Low-dose CT can still be used, but it can only be embraced in case-finding situations. Typically, you will present already with cough, with chest pain, and other signs of symptoms, and you are thinking probably you may not have TB. Then we subject you to a low-dose CT to just check if you have a mass, if that has to be embraced, or we just subject you to a CT to see whether you have a mass.
No,
so that's our
there's
approach.
something that I've always found puzzling. Maybe you can unravel it for us. Why is it that everything that is related to cancer, the treatment, everything is expensive? Why?
Interesting question. We have different approaches, and I don't know how well to begin this. First, we have very few oncologists in this country. We have very few oncologists, and that's why as an institution, Moi Teaching and Farrell, and together with AMPATH, we have actually there is a program that embraces building capacity for clinicians and nurses in oncology to enable them to carry out the baseline, evaluation for oncology and even management. In our program, most of the patients actually seen by the clinicians, yes, but in continuum of care, every new patient needs to be seen by a consultant oncologist, who are very few in that case. And that's why they cannot be able to handle every patient. They come in as a new patient, you're seen by the consultant, then you're handed over to a clinician for continuum of care. These clinicians must be capacity built. That is one. Secondly, treatment and availability of medication is quite a challenge. Today, as we speak, most of the advanced nation, they've advanced to targeted therapy, immunotherapy, for example, while we are still grappling with chemotherapy and probably radio. And even radio, for example, is not easily available. Moi Teaching and Farrell Hospital had the privilege of getting this radio just a year ago or so. But otherwise, we didn't have it. It was all in Nairobi. So any other patient who wanted to do radio, unless they are going into maybe private companies or rather private hospitals, all of them had to be sent to Kenyatta. Probably we had to work with the Nairobi hospital or such for our patients to get radio. So it is the structures, the workforce, the human force, the medication, the initiatives that are there, and this also leads me to even discuss briefly what we are doing as a lung cancer program, because to us, we would wish to further characterize these patients so that you can be able to embrace the targeted kind of therapy. It is more fairer than just subjecting a patient to chemo without really identifying the immunohistochemistry and then further characterizing this particular cancer so that you can be able to hit it hard.
All right.
Cancer is complicated.
Yes, it is.
Difficult to understand. So, if that is the case, then how then would you put into place or into play a preventative approach towards these cancers, specifically lung cancers, since that's what we're talking about.
Yeah, indeed. There are several preventive measures. One of the things is that we need to recognize what risks, what are the risks that then make you get lung cancer. If you identify the risk, then it is much easier for you to prevent the risks. Typically, most of our patients, a bigger percentage of our patients, if there is one single risk that has been singled out on most of these patients, is cigarette smoking, which is recognized in the entire world. But that doesn't mean that every smoker must get lung cancer. It means when you smoke, you are at a higher risk of getting lung cancer as compared to a person who doesn't smoke. However, even if you don't smoke, if you're a secondary smoker, then you're at a higher risk of getting lung cancer because the effect of tobacco has been recognized even in the chest and even in the general body. So that is one. And the other risk factors. Typically in our population, we're also realizing that there are some people who do not even have apparent risk of any of the things that are known, but they have lung cancer. They have lived their life well. They have not even lived next to a smoker. They have not been engaging in some of these initiatives, such things like, even shisha or hookah smoking. They have not been there, but they have lung cancer. So as you said, it is fairly a complicated situation whereby there is even the component of hereditary, if I may call it that way. If you have lung cancer, if your father has lung cancer, your father has cancer, whichever cancer, your brother has cancer, your sister has cancer, the higher probability is that you may also have cancer. It may be lung, it may be breast, it may be whichever way. But it's also very key for us to look at what are the causes of these cancers and what are the preventive measures for us to do so that we can advocate equally, so that in the long run, we find ourselves embracing the initiatives that are there to prevent us from getting exposed to lung cancer.
But I'm still a bit conflicted as to what these risks really are. If an individual, for example, you're saying that one of the highest markers that you're seeing now is cigarette smoking or even secondhand smoke, having been in the company of somebody who is an active smoker. And then you remove that. What else? Because I guess then the question is, what causes this particular cancer? Maybe difficult to say. So that we can stay away from those things. But then now we're saying, look at the risks. And if cigarette smoking is one of them, and we still have people who get lung cancer and are not smokers and are not in close proximity to active smokers. What else are we looking at that we would say stay away from, or this is what causes it?
If you're smoking and then there's this and the other, you're increasing the probability of you.
And as I mentioned, those are the risks. And what is key here is that in our program, and I want us to talk about the typical scenario that we are seeing rather than ones that we read about. The typical scenario that we are seeing is that most of our patients, a good number of our patients, and interestingly, lung cancer was known to be the disease of the age and mostly the men. But currently we are seeing almost a ratio of 1-to-1 with the women. One of the things that we've been able to point out as a program is that a lot of women population that have lung cancer have been cooking with firewood. They have been contained in the kitchen. The way traditional kitchens are set up. They don't have a chimney. They have a very small window, so the air circulation is not as much there. So we are also recognizing that the continuous exposure to firewood smoke is actually a risk factor. And this is something that we're working quite closely with some of the programs like the indoor pollution control to even construct and advocate at the village level houses that have chimneys in them, that we can be able to at least remove the smoke and leave the population that are there. A very good number of our women have done nothing in their lives. They've not been working in factories where they're exposed. They've not been subjected to asbestos. They've not been subjected to uranium or any other things that we may consider risk factors. The only thing they have done in their lives is cook for their husbands and their children, and yet they have lung cancer. So we highly suspect it could be closely related to inhalation of smoke within the cooking environment. What type of firewood causes this most is something that we need to do more research. But other things that are there is that we also have a lot of population now that you come from Uasin Gishu, because even when you look at the population coverage of lung cancer patients, Uasin Gishu actually does lead And this is not because there are more lung cancer patients in Uasin Gishu per se, but it could be because Uasin Gishu is proximal to care.
Yeah.
So a lot of patients are able to get care. Most of the patients that we also had from Uasin Gishu is that they're patients who have just dealt with farm inputs. Chemical spraying, use of, storage. You're talking about maize here, use those, use all those things, but we are not observing what we call the universal precaution. We're not using masks, we're not handling the chemicals appropriately, and we're finding ourselves getting exposed to these kind of risk factors. So generally, if I may say, just in summary, is that each and every one of us is exposed to agents of lung cancer. We cannot be able to say that because I don't smoke and because I don't cook with firewood, then I'm actually free. What is most key is that when you have that cough that you're not very sure about, get evaluated, get screened. And in that case, if you can be able to diagnose lung cancer earlier, the primary stage is actually very very early stages. It's actually manageable.
Okay.
You can actually do that with one lung, literally. You can actually do lobectomy and work with one lung. You may not run across the stairs or run a marathon, but you will live your life cancer-free.
What is the likelihood of lung cancer then starting to metastasize when you're now looking at those who have to wait for diagnosis? And I'm saying wait cautiously here because they don't know what the situation is.
Yes, interesting. And that's where most of our patients are found. When you look at the cohorts of patients, the groups of patients that you're having right now in care, 99% were in stage 3 and stage 4. In fact, when we find a stage 2 patient, we celebrate. Like, oh my God, we have a stage 2 patient here. It is a case study. Most of our patients have lung cancer that has already metastasized to other sites. And this is because of the very reason that I said we have our patients with us, but we diagnose them fairly late. If you find a patient who comes to the clinic and they're not improving and despite that they're taking medication and along the cascade, maybe before they die of whatever it is you're treating, you find them to have lost their memory, to be very confused, that is most likely lung cancer, because some of the areas that the lung cancer causes, besides the rest of the body, is the brain and the spinal cord and the rest of the part of the body, because remember where the lungs are. Circulation, literally the whole system passes through the lungs. So it is something that we are working very closely as a program, so that we make sure that we find these patients before the lung spreads to those margins, because it's quite an advancement in the event that we find these patients early. You can live with lung cancer for quite some time if you're in the right care.
So then it's not curable. You wouldn't go into remission like you would with other cancers. Is that what we're saying?
That's the best way. That's the best way to approach it. The remission component is not there. Cancers like multiple myeloma, for example, it's much manageable. You are found with it, you get into care, you may easily go into remission. But lung cancer, we're looking at two options. One is a stable disease. Stable means the mass is contained. It doesn't grow. Probably may reduce in size, but it doesn't grow per se. The signs and symptoms reduce. You go back to your work and you do your things as a normal person while on medication, on treatment, or when you've finished. And we're also looking at the progressive disease, where the disease does not yield to initiatives. So it continues. Wow. And this is usually when it has metastasized to other areas. That's the tricky part. So those are the two scenarios you're looking at. But as far as lung cancer is concerned, one of the things we're doing right now is to look at the three options that we have. One of it is cure. If we find it early, we will most likely cure. And in this event, we are talking about the approaches such as the surgical approach, doing lobectomy. If you can be able to be very sure that it's contained with a certain lobe of the lungs, you can actually do it. The other thing is probably just control, and that's where we are most of the time. We are controlling it. We are controlling it not to grow, not to make you live a lesser life of suffering. We're controlling it. We're containing it within that particular, so that it doesn't spread out. Right. But the other one is palliative. Palliative is when it actually has metastasized to all the other areas. So we want you to live the life that you have comfortably, without pain and without other things that may affect you, at least happily. So we're actually approaching the palliative care. But generally, every other patient who is diagnosed with lung cancer is initiated into palliative care.
Lawrence, there's another cancer that has been spoken of in greater measure than before, the esophageal cancer. And there is also literature that indicates its relationship with hot beverages, hot foods, and not just hot tea in Kenya, but there are studies in Iran, in China. Now, when we look at the case of cancers and the increased discussion around this particular topic, is it that we are better able to diagnose the disease? Or is it that there is a larger proliferation of it? Is it that our lifestyles have changed? Is it that we have put ourselves in positions that make us more vulnerable? Which is what exactly?
Interesting question. I won't want to comment much about the esophageal cancer. However, I have to say this, that the background of the clinical care, it is very prudent for us to understand that injuries to cells can exacerbate proliferation of cells. That is
injury to cells.
Yes, okay. And that cuts across. And that's why, even if I was to give you a typical example of cervical cancer, when a young girl has early sexual debut, it exposes her easily to develop.
Young girl, as in a girl whose maturation of the body hasn't reached.
Yes, exactly, exactly. Because there's injury, to the cervix, and as the girl grows, there's a very high likelihood of those particular cells to probably heal with fibrosis and probably exacerbate proliferation, because cancer is proliferation of cells out of control. It's the same thing. If you take very hot tea, it will burn your throat. Probably as you grow up taking very hot tea, you think you're becoming a champion in
drinking hot tea.
Drinking hot tea. But you're causing injury to the esophageal lining. Probably that can also exacerbate overgrowth of cells. But this is the point. As you have rightly put it, when you look at all these things cutting across, it's very key for us to understand at this point that as far as cancer diagnosis and lung cancer diagnosis is concerned, it is very important for us to look at what are the main causes, the known causes, and what are these other ones that we are actually discovering along the cascade. So I don't know if I've been able to handle your concern. Or
there's that question. Is it that we have more cases? Is a higher proliferation of cancer?
Indeed.
Or is it that our screening and
advanced? Now that is interesting. Two ways. When you look at lung cancer, considering it as a cancer that is exacerbated by environmental pollution, I could confidently say that probably the diagnosis has gone high by virtue that a lot of us are being exposed to causative agents. That's one. Secondly, the other cancers that have come up to be diagnosed by virtue that we have advanced in diagnostic procedures. For example, if I look at lung cancer, it's not that lung cancer has not been there. It has been there, but the diagnostic element has not been there. Typically, if you have a patient who is going to see a TB expert, for example, and this patient is suffering from lung cancer, but the TB expert does not know or does not have the index of suspicion. When this patient dies, what has this patient died of? In real sense, the patient has died of lung cancer, but the report will never report it as lung cancer because the patient was never diagnosed with lung cancer. And in our African setup, most of our patients, when they die and they have been seeing a TB expert, they have died of TB.
Yep.
But you see, TB has treatment.
Yep.
The real sense is that we don't take the initiative of going again to do a postmortem for this patient to find out what exactly they died of, yet they were seeing the TB expert and taking TB medication. This is a typical example. So you find that some of these cancers have not been diagnosed, were not being diagnosed early because of the index of suspicion. And as I mentioned in the beginning, when you see me walk into your clinic and you suspect I'm maybe suffering from this particular condition, your mind zeroes down to that particular condition first before it can think beyond that condition. So usually patients, when you come into all this kind of thing, it happens. Esophageal cancer, for example, the one you're giving me as an example, is a cancer that in one way or another also gets to be diagnosed quite late. Most of these patients will be managed for ulcers, for ulcer disease, for other conditions until that time that the patient cannot be able to swallow completely because now the mass has occluded. And that's when now we come in diagnostic procedures. So some of these things, because we have been able to advance, and trust me, unlike breast cancer that you can be able to see, Lung cancer, you can't see it. So it's not an obvious mass that will say, oh, let me take this biopsy. You know, you have to go through certain procedures to be able to recognize that mass and actually go in and take biopsy. That's one. Secondly, the other thing is that we have advanced technology. Previously, it's actually quite difficult to take a lung biopsy. It's only done by interventional radiologists. And I'll say this, in the Moi Teaching and Referral Hospital, there are only 2. And we're encouraging other doctors to come in and take this up. Because you can imagine 2 in a bigger referral hospital, an entire hospital.
The kind of population that they're dealing with.
Exactly. So interventional radiology is a technique that has come in where we actually take biopsies through either CT-guided or ultrasound-guided to ensure that then we actually have a biopsy taken, a sample taken, and taken to the laboratory. Because in cancer, in medical field, cancer is not a rumor. You don't come in coughing blood and say, oh my God, you have lung cancer. No way.
There'll be many other
we
things.
take the biopsy and take it through the lab, we can never mention or say that you actually have lung cancer. So,
Lawrence, thank you very
sides.
much for joining us today. It's an interesting and lengthy conversation that we wish to invite you again to come so we can continue with this and see what advances you're making at MTRH.
Indeed.
And all the good work that you're doing.